so much of this is going to then build on what Dr. Lafarge was then talking about, but now I'll speak more under the confines of junctional kyphosis and junctional failure. And if you look at the incidence of junctional kyphosis and junctional failure, at this point, I think we know that it's problematic, with very high rates. Obi Boachi said about 22%, Virgin Lafarge from our data after a PSO, almost about 40%. Brett Line just had this paper accepted for publication in Spine. We saw the junctional failure rate right about 14 to 15%, with revision rates about 7.5%. The problem, though, I think that, why does this remain problematic, despite all the research that we've done? It's probably because of the definition. You can't really then prevent what you can't define, right? And so we first need to get a handle on what it actually constitutes. What are we trying then to prevent? And if you look at then at the definitions of junctional kyphosis, right, it's this kind of whole slew of radiographic values that can range anywhere from benign PJK or benign kyphosis, which is what Obi's paper or Boachi's paper was that I referenced previously, all the way to catastrophic failure, which we're trying to capture now within then the ISSG. And so it's these patients then on the right that we want to capture, probably less so those on the left, because those don't really even matter. And so then the other problem is that there's multiple confounding factors, and we know from research standpoint that we know we have to hold some of these variables constant, because if you have a heterogeneous cohort with a whole slew of confounding factors, your research will make no sense at all. And so then the question comes of what are the solutions for junctional kyphosis and failure? Well, it makes sense that we've not come to a conclusion on that, because one, our definitions are terrible, and number two, we're not holding any of these concepts constant that are confounded. What I'm going to go into now, though, is looking at some of the discrepancies where the research lies, namely, is it an alignment problem or is it an implant problem? And can you solve this problem either with an implant or with alignment? And so if you look at the PJF biomechanical theory, right, it's this concept that you have this abrupt change from the rigid instrumented portion of the spine to then the highly flexible non-instrumented part of the spine, right, which is hypermobile above it. And again, so the solutions then either are to dampen those forces above with a hook or a tether or a transition rod, or to harden that proximal segment with cement, right, so they don't fracture. And there's been some data that supports that. We wrote this up to the ISSG. And again, you can see this is a little busy, but it makes sense. You can see going from the upper instrumented vertebrae to the vertebrae plus one, unbelievable range of motion going from about 2% to about 98%. And the thought then is this potential energy that is dissipated through this then leads to a failure, right? And so then you can see as we go and add a tether to those segments to dampen those proximal forces, you start to see this stair-step type pattern as we're dissipating those forces. Again, this is a finite element analysis study. I recognize there's a zillion problems with FEA, I get that. But again, showing these concepts that they potentially can work and we can dissipate those forces, right? And that's a concept between a tether that Dr. Kleinberg and I are going to show you then in the lab. We also then did the secondary finite element analysis with Tom Buell and the group at UVA, looking at the Bess then constructs. And in summary, we found that if you add a tether or some kind of dampening force, you want to add it to the UIV plus 1 and the UIV plus 2, because if you terminate just at the UIV plus 1, you're still going to get these abrupt changes, and that spike then from very low range of motion to very high range of motion. Which is interesting, though, because also we found that, at least with a tether, and we'll show you this, that the way you put the tether in, it doesn't really matter, so long as you include the UIV plus 1 and the UIV plus 2. You can loop it, you can weave it, you can tie it together, you can do all these wacko things, doesn't matter, so long as you're able to dissipate those forces. The other piece about that, though, which I think is most important on this slide, is these three sections, right? How you tension that tether matters. If you don't tension it enough, and again, we use newtons for this, if it's not tensioned enough, it doesn't do anything, right? It's still sloppy, and you have this massive range of motion. If you get it about 50 to 100 newtons, it's ideal, but if you over-tension that tether, then they fail at that segment, which makes sense, because you're turning then that tether into a pedicle screw. And then all you've done now is you've tightened down the UIV plus 1 and the UIV plus 2, and now created this force between those tensioned segments and the mobile segments. So what's coming from this? Clearly more work to be done. We also know the soft tissue matters. As Virginie was just saying, this is from Alan Daniels that did a very nice work on what happens if we don't alter the UIV. I realize you can't do this in every case, but if there are patients that have had then a prior surgery that have sagittal malalignment and you don't have to go up into that prior construct, what happens then if you alter those implants, if you take everything out and then re-instrument, versus if you don't do that and just focus down below and leave the proximal soft tissue envelope intact? I actually found that the altered UIV PJK rate or PJF rate was about 8.5%. The unaltered rate was 0, which again, it's not a solution, but it's giving us some ideas of what is happening with this pathology. Namely, it's a combination now not only of implants and force dissipation, but it's likely also then the soft tissue envelope and where you're putting those forces then above. The problem, though, I think then just looking at soft tissue and implants is we know it's not 100% effective, because at this point, there would be no PJK, which is probably not true for my practice, I know for sure, and probably not true for anybody's who's going to be listening to this talk. And so there has been less focus on alignment, and I'm going to build on what Virginie was just talking about, especially this concept of age-adjusted alignment. And she just went into this. If there's anything you can take from this talk, it is this slide right here and this piece right here. We should be able to disseminate to you guys. Renaud and Virginie Lafage put this out in Spine in 2016. Again, dividing patients into cohorts that were, quote, normal on the SF36 PCS, and then looking at their sagittal alignment. And we see again, right, in increasing values for the sagittal parameters, tilt, SVA, and lordosis gap, increases then with time, which makes sense because age, right, is kyphosing. And somebody who's 80 doesn't need the alignment of somebody who's 20, and if you do that, they're going to fail. And the reason why they fail, just as Virginie was talking about, if you extrapolate where the SVA would have been on these two patients, clearly both overcorrected. And likely, as you get older, if you take especially this person's SVA, where they would have been, look how far behind the sacrum they are. There's no way, especially somebody who's older and who's frail, can maintain that alignment. And then Renaud and Virginie Lafage again then looked at the risk then of overcorrection for age-adjusted alignment. And what we found is that with increasing overcorrection, there was an increase in PJK angle. What does that mean, right? That means, again, the more you overcorrect, the more they're going to fail and the worse the failure is going to be. And this study, which I think is also landmark, it captures this concept of junctional failure, right? Because again, as you're overcorrecting, you're having a worsening radiographic angle of PJK, and the patients can't tolerate it. And as Virginie was talking about at that last piece, I think somebody in the front asked, is it where, I think Peter actually asked, is it where you put the correction? And yes, it is. And this is done by Renaud and Brett Line that we published in 2017. If the disc spaces above your construct then are trapezoidal, and if those disc spaces that are trapezoidal abut on the UIV, you're at very high risk for junctional failure. The reason is all your correction is coming close to the UIV and it's not down below. So focus your correction down below. The reason I think why we see these continued failures again and again and again is that patients that then are forward and then you under contour rod and you york it down into the pedicle screws with your reduction devices, all you're doing is you're putting the correction above and they're gonna fail. So does it matter? Yes, it absolutely does. If, again, the proximity of your correction is adjacent to the upper instrumented vertebrae, that construct is going to fail and the patient is going to get PJK. So then, if we look at alignment versus implant, there's really been no studies based on what we saw previously. Implants can help, but alignment can help. But what if we compare the two head to head? And that's what we just had published a couple weeks ago in Spine, again, looking at a propensity matched cohort from the ISSG for patients that were either overcorrected or had an implant to prevent PJK, or had alignment-based then prevention for PJK. And so we wanted to compare the efficacy of either implants or avoidance of overcorrection. And so what we did is we took a cohort of patients and then looked at if they either had a PJF implant prophylaxis, and we looked at the type of prophylaxis, either a hook, a tether, or a cement, or nothing, right? And then we also, within that same cohort of patients, looked at those that were either overcorrected or those that remained within age-adjusted alignment, right? So again, two cohorts, no prophylaxis, implant prophylaxis, and then also overcorrected versus those that were not overcorrected. And then we used Virginie Lafage's definition of junctional failure based upon these formulas right here. Finding within the entire ISSG cohort, I referenced this previously, the PJF rate based upon that prior definition is right about 14% in our database. The revision rates right about 7.5% for those patients. Keeping in mind that there are some patients then that have horrific failures, but for whatever reason don't go on to have surgery. And we all have patients in our practice like that, have bad failures, we call them PJF, but they don't have surgery. Regardless, those are limitations for the definitions that we have right now. We then, rather than using historical controls for risk factors for PJF, we then looked at the risk factors in the entire database and identified age frailty, preoperative deformity, fusion of the pelvis, and the amount of correction as then risk factors within our analyzed cohort, which makes it more accurate because they're not historical cohorts. We then did a propensity score match analysis based on those identified cohort risk factors. And then we looked at first implant versus none. So we compare the cohort controlling for risk factors, right, for this cohort, take patients that either have an implant in versus patients that do not have an implant in. And we saw the demographics, the PSM worked, same for demographics, deformity, amount of surgery, amount of correction, and actually the amount of age overcorrection in this cohort as well, because we can hold that variable constant in the PSM only in this cohort. And lo and behold, look what happens, right? The PJF rate for none, if you do nothing, don't put anything in, about 20%, pretty high. Implant cuts that about in half, about 10.5%. The timing and surgical revision rates are about the same, but again, we see that the implants work, but it doesn't take it down to none. Quickly, you can look at this bar graph, and relatively similar performance. This is none, 20% PJF. Red is a PJF incidence, and yellow are the revision rates. And then we looked at hook, cement, and tether. Roughly, from a statistical analysis standpoint, hook performed a little bit better, but actually was confounded because there were fewer fusions to the pelvis in the hook cohort because our N got too low, and the PSM at that point, as you whittle them down, as you know, it doesn't work at that point. Probably the takeaway from that is they're all probably performing right about the same. There's not going to be, I can't proponent one versus the other for superiority. Namely, the implants work, but they don't take it to zero. But if you look at alignment, look at what alignment does. It's fascinating, right? And so these are patients, again, that had no implant prophylaxis, right? So again, you've got nothing in to prophylax for these patients, and you just focus on alignment alone in these patients. Look what happens. Failure rate about almost 25% for the overcorrected rate or overcorrected cohorts. That drops down to about 13%. So alignment alone within age-adjusted parameters, it works. It cuts the PJF rate in half. And so then, if we look at then the combination of the two, so this is the worst group at all, right? So this is the group you're like, I don't care. I'm just going to do my surgery. I never get PJK. I'm not going to put an implant in, and oh, by the way, that alignment garbage is for the birds. I'm not going to pay attention to it, whatever. Your failure rate's going to be about 25% if you do that. So about 1 in 4 are going to fail. That's probably a pretty bad rate. If you keep them in alignment, don't put anything in, but you align them, right? Cuts it about in half. Pretty good. And then if you add in something, hook, a tether, which we'll show you, or cement, it's going to reduce it even further. And that is this group here. So we take the no thinkers, the non-believers, the thinkers, and the believers, cuts it down to about 9%. So it actually works synergistically between the two. It doesn't hurt to zero, but much better, I think, than that what it's been. And so in conclusion then, surgical implants will help, but they're not going to do all the work. If you do nothing, your failure rate's probably going to be at least 25% based on this. And I don't think any patient in the world is going to sign up for a surgery where you tell them, you got about 25%, 1 in 4 chance of failing. They can make it, forget it, I'm not doing it, right? So you got to think. But if you just slap in an implant and you're not looking at alignment, it's not going to work. You got to be a thinker, right? And so that's why, again, I show this slide. This is the most important piece for this talk, is conceptually remembering the age-adjusted alignment. And if you overshoot these patients, they're going to fail every single time. Is it perfect? No. Is it a start? Yes. And the questions then come, how do we measure intraoperative alignment? And Femi Prodopsaltis is working on that on a project right now because we have poor measures of how we actually rectify what we do in our plan versus what we perform intraoperatively. The other question then, is it really age or is it frailty, right? Because there's some patients who are 80 going on 50 and some patients who are 50 going on 80. So as a consequence, those less frail patients may be better able to maintain alignment. And then the final piece is it alignment or is it a delta in that alignment? And it's probably a delta. You probably can't maintain an alignment, but as we were saying before, it's probably more you can't maintain an abrupt change in alignment. If you do scoliosis surgery and you take the curve from 90 to 0, there's going to be some changes in neuromonitoring. The motors will drop, right? And if you do that very quickly. Same thing happens here. If you take their SVA from 200 to 10, there's going to be some failures. And you can probably, in this analogy, see the delta and the drops in motors very analogous to what a junctional failure is. And so I'd be remiss if I didn't talk about two things, and I'd like to have Dr. Lafarge talk about this. Are there other than research ideas out there? Yes, there is. The ESSG did a thing called the GAP, the Global Alignment Proportion Score, looking at different spinal pelvic parameters. Gives a kind of a similar concept, out of proportion, within proportion. And again, this is from their article. You can see lower failure rates. The failure rates were confounded in this study because they're mechanical failures that can go into all of the holes with this. In fact, Renaud and Virginie Lafarge just wrote a paper comparing our data to that data, and there are some holes in it, but I think it maintains a similar thread to what we're reporting. And then finally, looking at the shape of the spine, the Rousseli classification, again, some holes in that, and it'll be interesting to discuss this. But at least my takeaway from this are the type 1 and the type 2 curves. If you look at the Rousseli's publications on this, those are the ones that failed. The reason why the type 1s failed, those are patients with thoracolumbar kyphosis. And I was taught you got to pull out that thoracolumbar kyphosis because it causes pain, and that is not true at all. If you pull out the TLK, they're all going to fail. And so, especially early in practice, I was flattening them, putting a lot of lordosis by my UIV, and taking out the thoracolumbar kyphosis, and they all fail right above that. If they have a type 1 curve, namely, if that patient has thoracolumbar kyphosis, get the lordosis down low, keep this in. You can bring the SVA out by correcting down low. And that's similar to what Virginie and Brett Lyon and Renaud Lafarge reported location of the lordosis. And then type 2 is obvious, right? They have a very low PI. And so they don't really need a bunch of lordosis. So don't overcorrect these patients. It's not rocket science. And I'm ahead of time. That's it. Thank you.
I might add to that. I think I'm not a big fan of hooks, and I think they probably work in patients who are less vulnerable, maybe, younger patients to begin. And I to echo what Shay is saying, I think in addition to being less disruptive of the soft tissue envelope, I think it is also, you're unable to use your reduction towers, right? So in order to put your rod into a hook, you're really reducing the rod into the upper end of the construct. So you're not creating pull-out force at the top of the construct and overcorrecting, which I think is fundamental.
You're not lordosing from a technique standpoint right by the UIV. Those concepts apply throughout the spine. So if you're using a base camp or a cricket or some kind of reducer, a high tab screw at your UIV, that construct's going to fail because you're pulling the rod in, you're going to trapezoid that disc space, and it's going to fail because the lordosis that you have is adjacent to the UIV. You're going to get that rod down in. And if you're pulled way back, it means you don't have enough L below your UIV. It's in the wrong spot. Other questions? Yeah.
I know you're going to have a demo in the lab, but can you talk briefly about the different technique for tethering on top of the exon?
Sure. And so the concept of different ideas surrounding the tether, I think a lot of it comes from this slide. Namely, we found it most effective by going to the UIV +1 and the UIV +2. So getting that stair-step force dissipation, not just at the adjacent segment. Because again, you'll have that steep peak. This is the FEA right here. If see right here, again, this is tethered. You still get that peak. Whereas we want this gradual stair step then dissipation by utilizing the UIV plus 1 and 2. It doesn't matter how you weave it. I can show you the way that we did it in this study. It doesn't mean it's the right way, just so long as you include those two segments. The other piece about that, again, is this concept then of over-tightening the tether. If you over-tighten it, it turns it then into, again, a pedicle screw, right? Because it makes that site very rigid. That being said, if you look at clinical failure patterns, the way it usually, if you use hooks at the UIV, it usually fails by a compression fracture at the UIV, and the UIV plus 1 falls over into it, right? If you look at the hook pattern, the UIV then falls over into the UIV minus 1, and the hooks pull out. If you look at how the tethers are failing, they fail at the level of the pedicle screw. What is that telling us? It's telling us likely that we aren't tightening the tethers enough. So I find the failure patterns interesting because if you change the behavior of something in a system, it means that you are impacting that system. It doesn't mean you have the answer, but if you aren't coming up with some kind of differentiator, they would all fail in the same way. And we're seeing the failure patterns different based upon the different concepts. Does that make sense? So we're doing something to it. We're not making it perfect, God knows, but at least we're doing something. Yeah.
Shay, great point about the rapidity of correction and the analogy you gave with coronal deformity. You take it from 90 to 0, we get nerve monitoring changes. And then, like, magnitude has something to do with it, age has something to do with it. Are you bracing your patients, and for how long, in addition to the tether technique, the age-appropriate alignment technique, soft landing constructs at the top?
Yeah, and so I think that so I am bracing them for 2 months. I think that reinforces behavior, and I'm probably doing that to treat myself as opposed to treat the patient, right? Because I don't think, because the vector is so far away from the spine that it can act as a reminder for the patients. Is it really doing anything for the patient? Probably not from a pure biomechanical standpoint, but it may prevent behaviors, and it may try to prevent bad habits. If they're going to fail,
Embrace the choice.
a TLSO, but not a clamshell, because they don't wear them anyway. And
Like, one of those prefabs.
that's right.
Clavicle.
Yeah. It's called a custom molded. So you can have an off the shelf, you can have a custom molded or a custom fitted or a custom molded. So the custom molded is clamshell, custom fitted is a Velcro brace, and off the shelf is some kind of garbage. I don't know what it is. So I use the custom fitted.
Do you do anything different for an upper thoracic endpoint as opposed to, I have started using cervical collars with or without a TLSO if I go to upper thoracic, thinking that I'm bracing the junction rather than bracing the construct.
Yeah, no, if I cross the cervical thoracic junction, then I'll use a cervical collar, usually into the TLSO. So it'll be a CTLSO. But not if I terminate at the UAV. Because many of my constructs, if I'm going to the upper thoracic spine, I'll terminate at T5, which I was taught never to do that, but now I'm using a tether, and so pedicle screws go into T5, and then the tether goes T4 and T3, or on a very frail patient, I'll use pedicle screws at T6, hooks at T5, and then tether at T4 and T3.
In terms of like optimization pre-op and after surgery, medically, is something that we didn't have time to talk about. But how big of a role is that in your practice? Metabolic, bone disorders, treating osteoporosis. Because I feel like even if we get the alignment perfect, if you have someone who's highly frail, high degree of osteoporosis, a lot of that gets washed out.
That's a good question. So. And we're sorting that out in CADS, as you know, right now. It's a prospective study that we have going, looking at lab values. If a patient is on a bisphosphonate or an estrogen receptor agonist, I get them off of that and put them either on some kind of parathormone agonist, right? So either Timlos or Forteo, we can say the trade names, I think, in this talk. I don't know the right duration prior to, because we know alendronate stays in the bone for probably 2 years, and so I don't put them off for 2 years. I get them off those two drugs, put them on either Timlos or Forteo, and keep them on that for 2 years. I base that, though, only on the lowest DEXA scan I have. I've not been dosing based upon frailty score. Yeah?
What's your DEXA scan threshold?
2.5. But the forearm is always going to be below 2.5 or below. Never use the spine, always use the forearm, because one, it's always going to be low, and two, it's non-weight bearing. And the DEXA scan is going to be confounded in scoliosis patients because the vertebrae overlie each other. And so you get that gantry effect where it gets 2 consecutive vertebrae, so it's falsely high. Use the forearm, and if they get pushback on it, because they say the spine is 0, but the forearm's -3, like, yeah, look at the forearm. Just use that, or just get the forearm, and it wipes everything out. Yeah.
If you go forward a couple slides that label risk factors,
Yeah.
it seemed like one of the significant parameters was pelvic fixation.
Yeah.
Sort of the lowest instrument for achievable level. Is that correct?
The
LIV stay from pelvis percent.
we only controlled for on this PSM with pelvic fixation. That is a known risk factor for junctional failure. But again, we thought it would be erroneous if we used historical risk factors, not applicable or analyzing this cohort, and then applying historical factors to it. I think statistically, that's an error to do that. We wanted to identify risk factors within the cohort and apply, but all these are known. This is yesterday's news. We all know that those are risk factors, right? But we confirmed it by running an initial analysis on the entire cohort. But that's no news to anybody. We know that iliac fixation is a risk factor for PJF. That's, like I said, that's about 10 years old at this point. Yeah.
In regards to your DEXA scan question, do you guys ever use Hounsfield units on the CTs?
That's a great question, but I don't know what they are, and I don't calculate them, and I think I would fail a test on Hounsfield units, and I couldn't argue with somebody. I like to argue, but that I can't argue.
But that's a great point. I've had patients with normal DEXAs, you get in there, put screws in the spine, it's like butter.
Yeah.
And all these measures are indirect.
Yeah.
Even if you take the best DEXA measurement, area hip, it's not going to be a direct measure of where you care about fixation, which is at the proximal junction.
Yeah.
So I'm getting quantitative CT scans with, distinct vertebra, especially where I think I might stop.
Yeah, and
thoracolumbar junction, T10 and T11.
Yeah. And Virginie, we deliberated having that in one of our prospective studies. There's only so much data you can get, and then it's also authorization for CT scans. And so again, if everybody doesn't have it, then the data sucks, right? And so then the worst case scenario is you're going to disprove it, right? Because your N is too low. So, but it's a great point. I don't think we know. Thanks, guys.